So in this day and age, you can pretty easily, fairly inexpensively, equip your office with office spirometer. An office spirometer. And with an office spirometer, you'll do things like measure forced vital capacity. And that's the maneuver that you're going to do a couple times when you're in a respiratory lab. And there are two basic approaches to doing this. The old-fashioned equipment is the spirometer itself. And sort of the more modern approach is to use a pneumotachographs. The spirometer is based on the principle simply of collecting volume over time in a big in a big tank. The pneumotachographs makes use of a lot of the principles you learned first semester from Dr. Breshew about pressure drops. Pressure drop across the resistance will give you a measure of a flow. And if you take flow and integrate it over time, you can get the volume that you expired. So you get two kinds of curves out of these instruments. You can get volume time curves and you can get flow volume curves relatively straightforwardly from the pneumatachograph. And we're going to look at another measure, FEF 2575, that's thought to be a reasonably good indicator or maybe an early indicator of small airways disease. If you're a pulmonologist, in addition to office spirometry, probably the most common other kind of test that you're going to do on patients is some measure of the patient's residual volume. And what you'll remember is that you can't measure a patient's total lung capacity without knowing their residual volume. You can't measure their functional residual capacity without knowing their residual volume. And of course, if you don't know the residual volume, you don't know the residual volume. So these are the three things that you can't measure with a spirometer. Why? Because residual volume is the amount of air you can't get out. So the instrument can never see anything that includes residual volume. So these are the three measurements you can't use residual volume for. Then the other thing that you often do, and we're not going to do this in lab, is a DLCO, which tells you something about the condition of the patient's membranes. So DLCO will go down if a patient loses cross-sectional area of their membranes in a disease like emphysema, or if their alveolar septa thicken, as it does in a disease like pulmonary fibrosis. And so DLCO is most often used in patients, usually with restrictive disease, where you want to differentiate between some extra pulmonary, that is thoracic cavity and pleura, versus the lung parenchyma itself, the gas exchange surfaces itself, as the cause of the patient's lung disease. So, the primary use of pulmonary function tests is to differentiate between obstructive diseases, which we said is difficulty getting air out, and restrictive diseases, which is difficulty getting air in, just sort of in simple definitions. Obstructive diseases include things like emphysema, chronic bronchitis, and asthma. Did I say asthma first? Okay, so yeah, emphysema and chronic bronchitis together called COPD. Okay, so don't think of them as different diseases. And asthma is the third one that usually goes in, and that's reactive airways disease. So like ECGs, pulmonary function testing are not diagnostic in and of themselves. They're just part of understanding the whole clinical picture of your patient, and they really have to be interpreted in the context of the clinical setting of your patient, history, physical exam, and so forth. So when you do a so-called forced vital capacity, what you do is you exhale the vital capacity into either a spirometer or a pneumatachograph. And what we find out is that the very first part of the air that comes out depends on your effort. Okay, so the peak expiratory flow depends on your effort. And some of you may have been around asthmatics that use peak flow meters to measure the status of their asthma. But to some extent, that depends on their effort. So if you're feeling kind of weak someday, your peak flow may go down, not because your airways got worse. But the beauty of the forced vital capacity maneuver in the later parts of it is it's effort independent, and it tells you about the elastic recoil of the patient's thing. So we're going to try and look at that in you guys, hopefully all of you looking pretty normal. So the technician usually has the patient repeat these maneuvers 3 times. We are going to make you do the more modern pneumotachographs 3 times. And each time the machine is going to say, this test did not meet an American Thoracic Society standard. And so it'll sort of explain why either you coughed or you did something wrong. And so when you do this maneuver, we're going to make you blow out as hard as you can for 6 seconds. And 6 seconds may not sound like much, but it's a lot harder than you think it is. Those of you who've used spirometers before will know that. And so the air comes out really fast at first, and then you think nothing's coming out, but your technician is going to be going, blow, 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 keep going, push, 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 keep going, a little more, a little more, a little more. And 6 seconds is going to seem like an eternity to you while you're doing that. Now we're going to make you repeat it 2 more times. Okay, so it really turns out at the end of the day to be lots of fun, and I'll try and demonstrate it for you here in just a little bit. So what do you do with all these measurements? Okay, so forced vital capacity is the total amount of air you can get out. And if you look here, here's a normal patient. And I guess this is supposed to be a typical 70-kilogram person. So they got 5 liters out, okay, altogether. And if they develop obstructive disease, they might only get 3.1 liters out. So they're going to get a decrease in their forced vital capacity if they have obstructive disease. And if they have restrictive disease, they'll only get 3.1 liters out. So they get less air out no matter whether they have obstructive or restrictive disease. Why? Well, the obstructive person has a decrease in forced vital capacity because it can't get the air out. Okay? The restrictive disease has a decrease in forced vital capacity because they couldn't get much air in there in the first place to get anything out. So if you have a small tank and you empty it, you don't get as much out. So this doesn't really all by itself help you differentiate between obstructive diseases and restrictive diseases. So the next thing we're going to look at is what fraction of your air did you get out in the first second? What I said is normal people get about 80% of their air out in the first second, even though we're doing the maneuver for 6 seconds. But if we look at patients with emphysema, COPD, asthma, what we're going to find out is that they get a much smaller fraction of their forced vital capacity out in the first second. And that's because of gas trapping and sort of their airways are tending to collapse because they don't have or mucus plugs are forming. So they're getting sort of intermittent flow from different regions of their lung. On the other hand, if we look at restrictive disease patients, their FEV1 to forced vital capacity ratio will either be normal or slightly above normal, okay? So they'll tend to have 80% or maybe a little bit more than 80%. The second maneuver the second measurement we talked about was FEF 2575. And you can think of this ratio as going sort of the same way as the FEV1 to forced vital capacity ratio. That is, in normal people, it will have a slope that looks like this. In obstructive disease, the slope will flatten out. That is, their expired air will come out more slowly over the middle half of their forced vital capacity maneuver. But if they have restrictive disease, it'll come out at about the same rate as normal people, or perhaps just a little bit faster, okay, in restrictive disease. And so if you notice, these go the same direction as the FEV1 to forced vital capacity ratio. The FEV1 is far more used clinically, I think, right now. The reason people even measure the FEF is because sometimes it's an earlier indicator of small airways disease. This table just sort of emphasizes what happens. So is FEV1 down in restrictive disease? Yes, but it's proportionately down to the forced vital capacity. So the ratio of the two is unchanged, or perhaps even a little increased. If you look at obstructive disease, you see a disproportionate decrease in FEV1 compared to the decrease in forced vital capacity, and so this ratio is down. And if you look at the FEF 25-75 arrows, they look just like the direction of the arrows for FEV1 to forced vital capacity. So it's easy to remember. When you look at these things, here was subject 1. And what you see about subject 1 is how flat the effort-independent portion of the flow volume curve is. Okay? And when you look at subject 2, what do you notice? It's just slightly more scooped out. Do you see the scooped out appearance of subject number 2? Subject number 2 has some, or at least a larger degree of airway obstruction than subject 1 does. So what happens is you tend to get some airway collapse, and that causes this very characteristic scooped out appearance. If you had somebody with real lung disease, this would be even more scooped out than subject 2 is. So all of us will become more scooped out as we get older. And if we are smokers or develop asthma or COPD, we'll become increasingly scooped out. So this is sort of the expiratory portion of flow volume curves. And what's different about this than the real ones that we just looked at is that we've added in residual volume just so you can have some context for what's going on in real patient lungs. But here's a patient, normal patient at a TLC of 6 liters. Blow, 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 keep going, push, 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 little more, boom. Done. And you see how flat this effort independent portion of the flow volume curve is in that patient. In a patient that develops restrictive disease, they can't get air in. So what will happen is they'll start here at about 3.5 liters instead of 6 liters. Although when you do the test, it'll line up on the spirometer because we don't have residual volume. This is offset to make it clear to you what's really going on. And so what you see in this patient is this, I don't know, violet loop here. And if you look, 4.5 minus 1, it's about 3.5 wide of vital capacity. And if you look at the normal person, it's 6 minus 2 and change. So it's 4. So this is a wider loop, bigger vital capacity than the vital capacity in the patient with pulmonary fibrosis. Then if we look sort of at obstructive diseases, and emphysema is the one that you can really look at, the first thing we notice is an increase in total lung capacity. Okay, you won't see that on the patient's trace because we don't have residual volume, so it will start at the same position on a real one. But what is happening in this patient, and you'll probably notice it on their chest, is they've become barrel chested. And so they have more air to start with when they're at TLC. And when they go blow, 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 they can't get air out very fast even at the beginning. So their FEV1 to forced vital capacity ratio is down. And this scooped out appearance will be a really characteristic of what a patient with major COPD looks like. Asthma and chronic bronchitis show the same kind of thing, but the scooped out appearance generally is just a little bit less when you have inflammation and mucus plugs causing the increases in airway resistance. So now we need to take a look at the actual lab procedure, and I'm going to take you through exactly what we're going to do. And we're going to do 3 repeats of a forced vital capacity maneuver followed by a maximal inspiration to create flow volume loops during both expiration and inspiration. And you'll remember that the American Thoracic Society would like us to maintain our expiratory effort for 6 seconds. And that's going to seem very long when you do this. But what's important is if you have patients with obstructive disease, that long sort of helps you learn what their true expiratory volume, forced expiratory volume is, because will be sort of gas trapping and the air will come out slowly. Before we look at the maneuver itself, you're going to need a nose clip. You're going to need your own sterile mouthpiece, which you will be inserting into the pneumotach with the fat end going into the portion of the mouth piece. And then you'll be blowing into this, but only after you put a nose clip on. And the nose clip is absolutely essential because when you are making a forced expiratory maneuver, there's almost always significant leakage through the nose if you don't have that clip on. So with that, let's talk about setting the software up and using it. So the first thing that we need to do is to clip on the new subject icon here. And what you're going to have to do is enter your gender at birth, your first name, your last name, your self-declared population, and this does make a difference in the calculation. So for example, I would pick Caucasian, put in your date of birth, your age will show up automatically for you. You need to put in your height and your weight. Your BMI will show up automatically for you. And then you need to decide whether you're a smoker, a non-smoker, or an ex-smoker, and then hit OK. So I previously entered my demographic information, and so the next thing that we need to do is to click on the forced vital capacity icon here, the third one from the left, and we'll get something popped up that initially says, please wait, and then you'll get a little click and a blow now. So again, we need to put our nose clip on. We have our mouth piece fastened to the apparatus, and now we inflate to TLC, blow out as long and as hard and as fast as we can, followed by a deep inspiration all the way back up to TLC. So you're going to be holding it for about 6 seconds. Ready? And done. So we get good test. We can take our nose clip off while we take a little breather before the next one. If you get a bad one, you can reject it and try again. This is a little bit difficult, so don't feel badly if you get a few rejections. Feel free to rest just a little bit in between them and then go again. So before the second one, nose clip on. Pick up your apparatus, TLC. And rest. Another good test. So we'll accept this one. We'll take a little breather before we do the third test. We need to get 3 of these. And last. And nicely, we got 3 in a row. So we can hit accept. Then we can hit return to take us back to the main page and click on the print thing. And it should print out, when you click on the print thing, it should print out on the printer on the other side of the lab. So you should be able to pick it up. Your report will have two sides on it, a front side and a back side. So one thing that you didn't see while I was doing the demo, because I don't have a respiratory tech doing the demo with me, is that a good respiratory tech is going to be encouraging the patient as they are doing this maneuver. And you as a physician can do that if you're doing these in your own office. But typically what you'll see as the patient is making an effort blowing into their spirometer is the respiratory tech is going to go blow, 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 push, 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 keep going, keep going, keep going, keep going, and encouraging the patient for the entire 6 seconds. This will help immensely for a patient to keep their effort. This really is, as you'll soon discover, harder than you'd think. And one of the things I'd like you to do as you are doing these maneuvers yourself is to imagine that you have a little old lady with broken ribs trying to do these in your office, and the kind of stress and strain that she's going through. So these are effort dependent tests in a sense, even though we end up talking about the effort independent portion of the flow volume loop. They do take quite a bit of effort from the patient. And as you do these, you need to be sensitive to the patient's clinical condition. So from here, let's take a quick look at what the tracing might look like. So looking at page 1 of the report, what we see is that we have the flow volume loop. And just for orientation, if you weren't watching carefully, as you blew out, the flow quickly came to a peak and then slowly fell off as you push, 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 blow, 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 blow. And then at the end of 6 seconds, you took a deep inspiration, which is shown as the downward part of the loop. So you'll see the flow volume loop that you're going to work on in the lab on the first page of your hand. And on the second page of the handout, you'll see the volume time curve. Blow, 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 keep going, push, 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 push. So it starts here and ends here. And then finally, you'll see a table of values which you need to interpret. The first column is the predicted values. Your best values are shown here with the various tests over here. And LLN stands for the lower limit of normal. And you have a column that shows you the percent that your values are of the predicted values. And then down at the bottom is just a little thing that shows you if you were in the green area or not. So that's our quick run through of the lab. I hope that you can encourage each other, and by the end of the lab that you'll understand sort of what these tracings mean and how you use them to interpret the respiratory condition of your patients.